okay? You can have your lunch during my lecture, okay? We'll have 1 hour of lecture this afternoon, and this will be followed by rationalization of the recent major exam. Okay, this topic is new in basic pediatrics, okay? In aligning with the SHED recommendations, this is now one of the topics in basic pediatrics, okay? This used to be part of third-year curriculum, okay? But we'll be focusing on basics of neonatology, okay? What we will have in third year will be the diseases among the neonates, okay? So this afternoon, this will be the scope of the lecture today. Some are in the PDF lectures in your Moodle, okay? We have videos also that are uploaded that you can view during your asynchronous hour, okay? So I will be discussing a little about the classification of newborns, okay? We classify them according to age of gestation, regardless of the weight, okay? So independent ang classification ng mga to. Then we classify them as to the weight, which is independent of gestational age. And then we have another classification, which is weight for age, okay? Accounting both these two factors. I will also discuss the cardiopulmonary physiology, the transition period, okay? Essential care of the newborn, and then normal and high-risk newborn in passing, okay? So first is the fetal to newborn transition. So we know that in utero, okay, the fetus gets the nutrients and the oxygen through the umbilical cord from the placenta, okay? And we know that the lungs are bathed with amniotic fluid, okay? So there is no gas exchange occurring, okay? At birth, the neonate is required to make a transition from placental gas exchange to a respiration that is totally dependent on the lungs, okay? Hence, the level of lung development greatly influences the success of this transition. And that allows prediction of the possible need for supportive care, okay? So we know that preterm neonates have immature lungs, have deficient surfactant, and other factors causing hypoxia, okay, and persistent fetal pulmonary circulation, and all of this will affect the normal transition. So the transition from a fetus to a newborn is the most complex adaptation that occurs in human experience, okay? Lung adaptation requires the coordinated clearance of fetal lung fluid, okay? We have now the importance of surfactant secretion, which occurs later in the 3rd trimester and hence affects the preterm neonates and the onset of consistent breathing. With the removal of the low pressure placenta, the cardiovascular response requires striking changes in blood flow, okay? Changes also in pressures and then causing pulmonary vasodilatation. We need the pulmonary vessels to vasodilate so that there will be gas exchange, okay? With the pulmonary vessels bringing the carbon dioxide into the lungs so that there will be gas exchange at the level of the alveoli. The newborn must also quickly control its energy metabolism and thermoregulation. The primary mediators that both prepare the fetus for birth and support the multi-organ transition are cortisol and catecholamine. So abnormalities in adaptation are frequently found following preterm birth, okay, or delivery by cesarean section at term. And many of these infants will need delivery room resuscitation to assist in the transition. So if the baby is term and delivered via NSD without any prenatal risk factors or maternal conditions affecting the birth, we will expect a normal and uneventful transition. So the amount of cortisol, thyroid hormones, and catecholamines all increase prior to the onset of labor. And these increased levels shut down the active chloride-mediated secretion of fetal lung fluid, and hence activate the basal sodium-potassium ATPase of type 2 cells in the airway epithelium. Okay, so of course, prior to birth, prior to onset of labor, the fetal lung fluid production should cease, okay, because in a matter of hours, the remaining fetal lung fluid will be reabsorbed by the lymphatics. So at birth, the secretion of lung fluid stops, okay, and this is now absorbed by the lymphatic system. Some of the fetal lung fluid during normal spontaneous delivery is squeezed out as the baby passes through the vaginal canal. That is why we expect babies delivered via cesarean section to have maybe manifestations of more retained fetal lung fluid for a little longer period of time, okay, than those delivered via NST. But of course, some babies delivered via NST will not have these benefits if they are delivered as small for gestational age, if delivered to a multigravid mother. Okay, so these are other factors to consider. So basically, the fetal lung fluid is absorbed into the lymphatic system and interstitium of the lungs. The next essential component for a smooth transition is having enough surfactant lining the alveoli, okay? So what are the surfactants? These are secreted by the type 2 alveolar cells and acts to reduce alveolar collapse by decreasing surface tension within the alveoli. So we know that the alveoli during inhalation expands, and as the neonate exhales, it will almost partially collapse or totally collapse, okay? Now, the pressure inside the alveoli, that's the surface tension. If it's high, the alveoli may remain collapsed, or there is difficulty in reinflating the alveoli, okay? So how do we decrease this surface tension? Through the presence of surfactant. So that's the important role of surfactant in the lungs, okay? So your surfactant decreases inflation pressure, okay? Improves lung compliance, provides alveolar stability, and decreases the overall work of breathing. So if you see an infant who is dyspneic, tachypneic, preterm, and that's the effect of having deficient surfactant. Some or most of the alveoli probably are collapsed, and therefore there is hypoxia and then labored breathing. Okay, these are the consequences of having deficient surfactant. The surfactant also enhances alveolar fluid clearance, okay, foreign particle clearance, and serves as a protective layer for cell surfaces. So the key to a successful newborn resuscitation is to provide adequate ventilation. Fortunately, 90% of babies do not require any form of assistance to breathe, okay? So we just see them the moment the baby is born, the moment the umbilical cord is cut. We are all waiting for the cry of the newborn, and that's music to our ears. Okay, the moment they cry, that's the sign of they are inhaling air and that they are transitioning well. So the normal fetal to neonatal transition results in the rapid onset of vigorous breathing or crying, okay? And this is because of the combined stimuli of cord clamping. Once you clamp the cord, there is no more source of oxygen for the neonate, and that stimulates breathing, okay? And this leads to probable removal of rapidly catabolized prostaglandins that suppress breathing. The diffuse tactile and cold stimuli act centrally, and also changes in PCO2 and PO2 levels in the blood affects this transition. So in the absence of hypoxia, virtually all term infants will effectively initiate breathing. Okay, so we observe for hypoxia manifested probably as pallor or cyanosis, labored breathing, or not crying. Okay. Another essential component for a normal adaptation is the transition from a fetal type of circulation to an adult type will be the endocrine support, okay, and changes in the pulmonary vascular resistance and pulmonary blood flow resistance. So we know that in utero, the pulmonary vascular resistance is high, and that the pulmonary blood flow is, the pressure there is lower, the arterial pressure there is lower. So in the fetus, blood flow to the lung is 1/5 to 1/10 the amount of blood flow found extrauterine. There is high resistance to blood flow in the arterial bed of the lung. Okay, that's why you have fetal pulmonary hypertension, which is normal. Okay, because the lungs are not functioning for gas exchange still in utero. Okay, this resistance is further increased by hypoxia, which may occur after birth. Okay, so some neonates may remain hypoxic after birth despite oxygen support, and that's why we refer to it also sometimes as persistent fetal pulmonary circulation, where the pressure is high. So when the baby is hypoxic at birth, that means that the pulmonary vascular resistance remains high. Okay. The pulmonary artery pressure decreases below the systemic pressure. Okay. Hence, the pulmonary blood flow increases. Okay. The left and the right ventricles pump in series rather than in parallel as in fetal circulatory pattern. Okay. These changes in pressures in the right and left sides of the heart would promote closure of the different shunts found in the fetal circulation that bypass the lungs. So if the pulmonary pressure decreases and becomes lower than the arterial pressure, then the blood flow in the atrium will be from left to right, hence closing your foramen ovale. Okay. So to achieve a normal neonatal circulation, the following changes must take place. Closure of umbilical arteries within minutes after birth, and ligation of the umbilical vein or clamping of the cord. Actually, these are both clamped and ligated once you cut the cord. Okay, you cut there the artery and the vein. One pulmonary vein, and two umbilical arteries. So ligation of umbilical vein, both of these are achieved by clamping the cord, as I have said. Closure of PDA then happens, which may occur within minutes to days. Okay, the PDA closes once the pulmonary pressure goes down. Okay, so in utero, the PDA is open because the blood bypasses the lungs. From the pulmonary artery, it goes to the ductus arteriosus and to the systemic circulation. Why? Because in utero, these are oxygenated blood coming from the placenta. So closure of foramen ovale also occurs, as I have said earlier due to the increased pressure in the left atrium and decreased pressure in the right atrium. We know that blood flows across a gradient from a higher gradient to a lower one, from a higher blood flow to the lower blood flow, from higher resistance to the lower resistance. And the last component for a normal transition is endocrine support. Substrate embryogenesis. So for all the previously mentioned adaptations, critical are changes in the endocrine function. I've been mentioning important mediators that prepare the fetus for birth and support in multi-organ transition. And these are cortisol and catecholamines. Okay, they are critical. And the thyroid hormone is also a mediator, though it only has a supportive role rather than as an acute modulator. So another change that a newborn must face is a change in energy source. Okay, fetal energy needs are supported by what? By the transplacental transfer of glucose to the fetus. So we know that the maternal glucose can be placentally transferred to the fetus. Okay, although the fetal liver is capable of gluconeogenesis from early gestation, this is minimal during the normal fetal homeostasis. So it's inadequate to support the need of the fetus for glucose and energy. So as term approaches, glucose and other substrates are being stored as glycogen and fat in anticipation of birth in the high insulin and low glycogen fetal environment. Okay? Remember that as maternal glucose is transferred to the fetus, the fetal liver responds by increasing insulin. So the insulin is produced and secreted by the fetus in response to the maternal transfer of glucose. But you know what happens if you cut the umbilical cord? You abruptly disrupt and discontinue the transfer of glucose. And that is at the time when the fetus or the neonate still has high insulin. Okay? So with delivery and cord clamping, we now cut maternal glucose supply. And the plasma glucose levels no